all things being equal, say, you're thinking like something around the thoracic duct for like a level of injury or something in the chest. Does right or left particularly matter to you, or just whatever side you're more comfortable on?
I will start on the side of the table that we use for most tables are set up for right groin access.
Sure.
So by default, I just start there. And what I do is once I have that access, I just put my injection apparatus down. I go and I access the other side.
Okay.
And what I do is I add additional tubing on the other side, and then I come back to the right side and I inject both sides simultaneously. And we kind of play a little bit of a race to see which side moves up faster, and you'll be surprised for whatever reason. One side may move up faster than the other. And there is a relationship between the lymphatics and veins and venous drainage.
Sure.
And sometimes you'll see some degree of shunting from one side, whether if they've had prior surgery, prior DVT, some type of other pathology, to the lymphatics necessarily drain back to the venous system, whether it's at the thoracic duct terminus or at stations along the way. So if one side isn't giving you the filling that you want, that's why I always do both sides to increase the chance of getting that filling in the retroperitoneum, which is where the money is, at least from a thoracic duct standpoint. So I'll do both sides very often. Generally, most of my lymphangiograms only require between 10 and 12 cc's of dye before I've already seen the cisterna chyli, and I'm ready to do an advanced intervention at that point if needed.
Okay. As far as accessing the cisterna chyli, any tips for that? Like one, seeing it, recognizing it, and then accessing it in a way that sets you up for success if you're going to have like an intervention that you're kind of planning for.
Yeah, that's a very important question.
Loaded. Yeah.
Once, what I do is I follow that most opaque portion of my lymphangiogram with spot radiographs.
Okay.
Because almost necessarily, with fluoroscopy only, you're not seeing kind of the leading edge of what's happening, and it's likely the lymphatic dye has actually moved further up than you think it has on fluoroscopy alone. So I'm always looking higher up than where the opacity is on fluoroscopy, and I'm taking a spot radiograph. And frequently what happens is you'll see the dye shoot up through the thoracic duct fairly quickly. It's really only when it is accumulating, that droplets appearance, that you start to see it on fluoroscopy. So what I do is I really start taking a look. I take spot radiographs at the very beginning of the whole patient.
Okay.
Chest, abdomen, pelvis. And then I'll take up magged spot radiographs somewhere between L4 and T8, just to see, hey, do they have any hardware, anything funny? What are the things that may impact my visibility of the lymphatics? And then once I have that opacification of those retroperitoneal lymphatics, I move up to that same mag again, and I'm really paying attention to the flow dynamics. And, it's not that I just want to see a big target there, because that big target could be a lymph node. I want to see a target, and I want to see transmission from the target, not going to another lymph node.
Okay.
Right? Because then I can access it and potentially pass a wire through it. As I've gone along, I've moved more to almost exclusively using a 21 gauge Chiba type needle, not a trocar tip needle, because the trocar tip has this diamond that extends a few millimeters beyond the actual needle itself. So you think you're in, you take the inner stylet out. Well, that's actually a few millimeters ahead of where the rest of your needle is. Whereas a Chiba, the inner stylet is flush with the tip. So you take out the inner stylet, and your needle is actually still where it was when the inner stylet was there. I put a very gentle bend, maybe 10 to 15 degree bend on the Chiba. I approach with a bit of the angulation pointed towards the head.
Yeah.
So maybe a 10 to 15 degree angle that way, or you can angle your II to help guide it. And I try to make it as straight a pass as possible, because with some degree of respiratory motion, enteral loops, distending, et cetera, with gas and things like that, it can really change the trajectory. And what you really want is a nice straight thing, so you don't have unnecessary or redundant loops in your course from the skin to the lymphatics. And then I probe usually with a V18 wire, and you really want to see it shoot up and straight. Every once in a while, it may be in the aorta or in the IVC. That happens. It's completely expected, generally very safe with a 21 gauge needle. I mean, our forefathers in IR used to trocar aortas with like
That's right.
six French, needle catheters and things like that, and just pull out.
Sure, cost of doing business back then.
Well, we freak out about hitting it with a 21 gauge. It'll be okay,
So, okay, so you're approaching target. Once you think you're in, are you doing anything to confirm in the lateral projection or?
I think that's a great point. Sometimes I'll use the lateral projection if there isn't enough dye filling. But if the dye is already filled, the thoracic duct, and the wire is clearly interluminal and moving with that type of interluminal feel you expect it to have, as opposed to having, some resistance or feeling weird in the retroperitoneal fat, or, when you're not really in a vein, etc., then I don't tend to go lateral, but I always encourage it, particularly as you get more experience with the feel.
Okay. Once you have wire access, your wire shoots up, you feel like you have, whatever working wire you have. I think you mentioned V18. What's your next line as far as like having stable access, bare back versus if you're planning, and we're assuming now that you're planning in something like an advanced intervention, like an embo?
My go-to catheter ends up being a 2.4 ProGrate. You can get a wide variety of sizes of coils and anything else to flow through a ProGrate pretty easily. If you want to do better quality diagnostic imaging, it's obviously easier to inject through a 2.8 ProGrate rather than a 2.4. The reason I like the ProGrates is they have a little stiffness to them. They're a little bit more reinforced than some of the other catheters, like an STC, for instance. So I feel like you have that ability, and they tend to track pretty well. I think a lot of trauma products are known for the trackability, for instance. So I feel like that tracks pretty easily over the V18. On occasion, if I've ever had trouble getting it in, maybe my angle is a little bit weird, or, it's not perfectly straight. What I do if I have a V18 in is I take like the inner metal and the inner dilator of a Mac NV kit or an AccuStick, that are about 3 French. And I use that metal to kind of support and get that other catheter in to help straighten out the tract. And then I can come back. At that point, because I've done that, I'll probably go in with a 2.8. If I ever want to change from a 2.4 to a 2.8, that's what I also do. You can get the metal down pretty close to it, and then usually the outer dilator with the 3 French will cross over. A couple occasions where it's been a little bit challenging, I'll use like a Navicross with a ProGrate inside of it just to support to getting down there. But in general, you don't want to have, the bigger your access in there, the higher the risk that you're going to have gone through something that may cause you a problem at the end. But in general, you want to keep it below 4 French.
Okay.